And hello, everyone. TJ Alds, I-45 now. Welcome to another edition of Healthcare Unmasked, presented by UTMB Health. An exciting topic we always do this time of year as we get ready for our Go Red luncheon coming up on the 25th of April in South Shore Harbor in League City. Always a popular event, but we always are talking about cardiovascular medicine when we're doing this special show that we are doing today. And again, too, we'll be talking about that Go Red luncheon coming up. Tickets still available. We'll get to more details about that a little bit later. We're glad to have everyone on with us that are joining us and watching today. If you have questions, make sure you submit them in the comment section. We're not in studio today. We're all virtual today, but it still is going to be something great when we get all of our information out for you. Very important stuff, some great stuff. We had as everyone knows, we do our pre-interview that happens on every Monday before the show. And this is some exciting topic. Not only are we going to be talking about what's happening as far as treatments in cardiovascular medicine and all, but we're also going to be talking about the research side of things as well. And a brand new program starting up at UTMB Health. It's called the Cardio Obstetrics Program at UTMB Health. And we're going to be talking about that as well. So we got a lot to get here for you today. And joining us now are our guests here today. Let me first bring up, we have Dr. Danielle El Hadid. She is an assistant professor in cardiovascular medicine, also still treating folks on a regular basis. There, we say professor, we got to make sure folks know they come in and see you on a regular basis too. She's one of the co-chairs, by the way, of the Go Red Luncheon this year. And also joining us is Dr. Diane Galima, joining us also from assistant professor in cardiovascular medicine, but also one of the top researchers on cardiovascular medicine as well. And we're glad to have y'all both on the show here today. Thank y'all for joining us. We appreciate it.
It's good being here.
Did we have, I think folks' mics are off there. Do we have them back on? Oh, no, I'm sorry. I had my volume turned down. My apologies. Now I can hear y'all okay. That's what I get for doing that, to get things off. Let me first let you introduce yourselves a little bit here. And I also find it interesting, Dr. Galima, is that not only are you in the cardiovascular side of things, and you revealed this when we talked the other day, but you're also, it's called experimental psychologist. In when you work with health-related research, talk about how that role of experimental psychology also works into your research side of things.
Sure. So yeah, as you mentioned, I'm an experimental psychologist. So my training is as a psychologist, but not as a clinical one. So not on the treatment side, but really trying to gain a deeper understanding into the behavior of people and why they do, how the things that they do, and how you can help them do the things that you would like them to do. So that was my training and my background. But 12, 13 years ago, I started working with clinicians at University of Vermont, specifically cardiologists and also some pulmonologists, really seeing what we could do from the experimental psychology side to inform the clinical side and really bring those two fields together to really have some exciting collaborations across those two different groups. Because I find it really helpful to have that connection between the researchers and the clinicians, because the clinicians really have a good idea of the day-to-day, what are the issues that they're dealing with. And then from the experimental psychology research side, I can help them with developing the kind of research ideas into actionable protocols and how do we test these things that they're looking at.
And one of the, I find this is a fascinating part of your bio, by the way, is the fact that you work you specialize in an area of, it's called, and this was secondary prevention. And we know about first line prevention, but what's secondary prevention? Because I found that when I was reading more and more about that, of what it entails, and this is probably the more important part of things. Yes, we want to prevent things up front, but your secondary prevention research, what is that about?
Well, I'm not going to get into an argument about what's more important, primary prevention or secondary prevention, because obviously those are two very important things. And it would be great to do primary prevention to keep people from having cardiovascular disease as an issue in the first place. But secondary prevention, so this is the idea of what can you do to help people when they've established the disease or they have had the event. So when we're talking about cardiology, I have a lot of expertise in what we call cardiac rehabilitation. So this is secondary prevention. You've had some sort of event, you've had a heart attack, you've had bypass surgery, and what do you need to do from that point on to really help you recover and to reduce your chances of ending up back in the hospital. And so there's a huge area focused on that. And we learn a lot about what are the important things that you really need to do. Like, for example, building up your cardiovascular fitness, your physical fitness is one of the most important things that you can do after you have an event. That's a great predictor of how you do going forward. And then another area that I do a lot of research in is in tobacco, and smoking cessation is probably the other number one thing you can do after you've had an event to prevent having, future events.
Well, and so we'll be getting more into what your research has found as you've been working on. Also joining us today is Dr. Danielle El Hadid. And as I said, she's the assistant professor and in the Division of Cardiovascular Medicine at the University of Texas Medical Branch. Most important part is that she got her internal medicine residency at UT Austin. So I've got to make sure. My biasness shows through there for sure. And we're going to get into this a little bit later, but I just want to give you a brief, Dr. El, give us a brief description of cardio obstetrics program you started out. It's so new that it's got like a one pager on the website. You're building that out, but talk about that effort that you're working on right now.
All right. So cardio obstetrics is technically a subspecialty of cardiology, taking care of pregnant women as well as postpartum, so up to 6 to 12 months or even lifelong. Now, it all started because the U.S. Maternal mortality ratio has been increasing, and that is due partly because of cardiovascular diseases and mainly peripartum cardiomyopathy. So I think it is important, as cardiologists are all kind of bystanders most of the time, and they're asked now to get to intervene early on these patients, if possible preconception in patients at risk of developing cardiovascular disease during pregnancy and postpartum. So also during pregnancy, along with MFM, we need to work together to have a safe delivery. So ideally, cardio obstetrics goes on from pre-conception up to a lifelong follow-up, because these patients are, after a year, 2 years, 3 years, still at risk of developing cardiovascular disease earlier than other people who did not develop cardiovascular disease during pregnancy. Yes, so that is.
That made me throw you off. When the screens go back and forth, right? Yeah,
exactly. I was like, "What's going on?"
It's just me coming back in to join you. So, but we're going to talk in more detail about that down the line. But as always, we do with this show in April, is we want to be able to get into explaining how cardiovascular health. There's been a lot of changes. There's always kind of involving research, involving care that's going out there, and we want to make sure we're touching on that. And when we come back, we're going to talk to Dr. Glema about Dr. Glema about looking at the differences between men and women and how you should approach those things. And we'll be doing that right after these words from UTMB Health.
There's nothing more important than quality health care for you and your family. That's why UTMB Health is in the communities where you live, providing easy access to innovative care. At UTMB, we know our patients need personalized care to lead healthy and fulfilling lives, providing everything from primary care and specialty care to urgent care and emergency medicine. UTMB knows healthcare. UTMB knows you. To find a UTMB doctor near you, visit utmbhealth.com.
And welcome back to Healthcare Unmasked, presented by UTMB Health here on I-45 Now and Pod Now. As we get into the show here now, as we're talking about cardiovascular medicine, Dr. Glema, I wanted to get into a part, because when we focus on Go Red, a lot of the focus leading up to that is about women's cardiovascular health, and there's a reason for that, because if there's one part that really changes up in medicine is when you talk about symptoms and approaches on cardiovascular health between men and women. There's a vast difference between those, including how the individuals react to it. I wonder if you can talk about and explain those differences for folks to better understand. about the risk factors for cardiovascular disease, how they differ between men and women.
Yeah, so there's definitely also, as you were alluding to, there's differences in how how cardiovascular disease presents in men and women, and perhaps Dr. El-Hadid can touch on that more because that's important as well as far from people knowing what to be looking out for. But like I said, my focus in research is on behavior and risk factors. So one of the interesting things that we can look at is what kind of risk factors are differentially worse for women to have and which ones are actually more protective for women. So I had talked briefly about, my interest in tobacco use as one of my research areas, and that's one where we see this discrepancy in kind of how that risk factor affects men versus women. So when we talk about some of the more serious heart attacks, the ones we call the ST elevated MIs or STEMIs, you see really interesting differences between men and women and how smoking affects the rates of having these events. So for smoking in general is really bad for heart attacks. It doesn't, recommend that everybody quit smoking. That would be great. But especially when you look at the younger women, the effect of smoking is disproportionately worse for the women. So, for example, if you have a younger man, his chance of having one of these STEMIs might be, 4 times higher than that of a man that's not smoking. But in women, it could be 6 to 8 times higher than a woman that's not smoking. So we see that, the effects of things like smoking are even more pronounced in these younger women.
And we talked about this on Monday, so I wanted you to kind of update. Is that what are the factors you think that make that difference between younger women on the smoking factor versus men?
Well, I mean, there's a lot of mechanisms that could be at play there. So not, we can't dial in 100% sure about what is the one thing that's happening, but one that's probably at play is the effect of different types of hormones. So obviously, if we're talking about the younger women, we're talking about women that are still in their reproductive years, they haven't gone through menopause, yes. So the effects of hormones like estrogen are probably more at play here.
And I found that when we were talking about the other day is a part that would seem common sense on that of how your body reacts based on those times. And trust me, and I'm one of those who's kind of blown it off over the time. Obviously, if anyone looks at me on camera right now, they know I'm not in the best of shape. And luckily for me, I get my cardiovascular health checked out at UTMB Health and with y'all's team and Dr. Janine there. And so does my wife, by the way. And when we compare notes about what we're told and what we see and what we're seeing on there, it is a difference of that, even though if we're having the same symptoms. And I think that confuses some people. Like if like the other day I was complaining about tightness in my chest, I was telling my wife, and she was like saying, well, Dr. Nee says I need to do this right away. I said, well, he told me something a little bit different variety. And so that's also is the discussion that you would have between men and women. And Dr. El-Hadid coming in on this as well, because you're treating patients on a regular basis, that there is a difference in how you communicate this to the individuals too. Is there not? There's not a cookie cutter way to say, okay, everybody has to take. Yeah, we know the not smoking and that, and take care of yourself. But there's more of a nuanced approach depending on who the patient is it not?
It is. Go ahead.
I would say historically, men the way that we have diagnosed these things have been based on the symptoms that men show. So there's been this underdiagnosis of events in women because our existing structure was built on how men present. And so Dr. El-Hadid, please detail.
Yes, I mean, women tend to have different symptoms than men. Men are more typical. But I mean, it's getting better. I think that women tend to, they're taken care of better nowadays. And given the recent research, the studies that have shown that morbidity and mortality in general is worse in women and STEMIs, meaning a heart attack. So I think it's getting better, but we are still way behind with women health, unfortunately.
And what's being done to combat that, to do better in the field, and also the patients themselves of dealing with cardiovascular health?
So I just think awareness, mainly awareness about this problem. The research that came out in a couple studies have shown that the morbidity mortality is pretty intense, pretty significant compared to men of the same age and coming in with acute coronary syndrome in general. So I think it is important that people keep educating and make sure that women are treated the same way as men, and there's no this gap between these two genders. But I see way better outcomes in UTMB for sure. The past few years, I've seen better outcomes in women. And we just need to know that women tend to present at a later age than men, approximately 10 years. And that's because of the menopause that is protective. At some point, we lose the protection when we reach menopause. But I think also research has shown that women tend to have 90% chance, the same as men, the same symptoms like typical, rarely atypical, but we still need to consider the atypical symptoms in women more than men, for sure.
Yeah. I would say that I think there's been a good push for, trying to raise the awareness that cardiovascular disease is still the #1 killer of both men and women. So it's really the thing that we should be focusing on. So that awareness has come up. And there's also been these, pushes with infographics and such of just trying to sensitize people to what some of these atypical symptoms look like, whether it's the fatigue that might be more present or the diffuse pain rather than the typical you might see in men. So I think as we continue to get that information out there, the awareness goes up, and hopefully women can kind of fight more for themselves when they're having something and they know something's not right, but they can advocate for, we need to get this checked out.
Right. And one of the things too is that we have to also understand that on the medical side of things too, is that the practitioners for the longest time were mainly just men. And so that was kind of the focus, and the kind of the culture was different. That's changed drastically now. We were talking about this amongst ourselves the other day, is that there are more and more women now, even more than a decade ago, that are in cardiovascular medicine now, both in the research side, as we see here, and also on seeing. That's made a huge difference, I think, in this, has it not?
It did for sure. I think the main problem was, women tend to come to the appointments of doctors and to the emergency room when something's wrong. But I think it's partly from the other side, mainly the medical staff, that may not have taken care of them as another male similar situation. But given that we now have more medical female doctors in all specialties, not necessarily in cardiovascular. I mean, we're still way behind. We're at 15%, 20% of women. But I mean, there's more women in general in medicine, which is amazing. I think it's even approaching higher than 50%. So I think this has changed in general. So the first encounter has improved the care afterwards. So I think it's mostly the first whoever assessed the patient who's more aware and sending more patients to the right, referring to the right people at the right time. And that is what is improving outcomes, I believe, more than anything. It's not mainly cardiologists.
And Dr. Klima, are you seeing too on the research side that's helping out too, in that you're being able to do more specialty research in for women, so you can focus more on the kind of showing those differentiations on, particularly like you talked about early on, the secondary side of things, the smoking effects, as you already pointed out, a difference there. That's also helping on the research side, is it not?
I mean, yeah, obviously we've had disparities on the research side and the representation of women. I mean, many of the samples that research was based off on the highly biased towards men, and the middle class white man at that. And so what we do see now is we see more scrutiny of the trials that are happening and what the proportions of women that are being included in those trials are. So we haven't reached parity yet. Obviously, I think we start seeing samples that are more, 30% women, 40% women. But, at least it's better than the 15% women or something that we may have seen previous decades, but you really do see more of people recognizing that and calling it out and being, where's your representation? How can we generalize this to women? And part of this is, the greater scientific community, like NIH, for example, required that we started doing sex-based analyses, years and years ago to try and really push the inclusiveness of what was going on and the generalizability. So I think that is slowly working its way through. It is a process. And on the second side too, I do think that we see more women that are in research and in medical research. And one thing that I think we still need to keep an eye on is that we have really good representation at the assistant professor and the lower levels, and we need to make sure that that's continuing on when we get on into the associate and full, because the higher levels are still really, really disparate.
Right. Yeah. It's a matter of getting the right place and the right people in the right place along the way. When we come back, we're going to talk about some of the risk factors you may not think about, including the fact, and I'm going to admit it right off the bat, I'm probably going to be guilty. Not probably. I know I'm guilty of this, of what you consider to be physical activity and the difference between what people say and how you can do a better job of monitoring that. That's all coming back here on Healthcare Unmasked, presented by UTMB.
UTMB Health knows that when you need advanced surgical care, you want a specialist who's an expert in their field. Our surgeons provide innovative and advanced treatment options for adults and children, for neurosurgery, GI, heart surgery, ENT, urology, and more. UTMB knows surgical care. UTMB knows you. To find a UTMB Health specialist near you, visit utmbhealth.com.
And welcome back to Healthcare Unmasked, presented by UTMB Health. We're talking about cardiovascular medicine, research, and treatment as we get ready this month of April, as we focus a lot on heart health, and then coming up the Go Red Luncheon that's happening on the 25th at South Shore Harbor. One of the conversations that the three of us got into on Monday that I wanted to touch on now was, what is, someone says they feel fine, but it comes in, Dr. Hadid, when they come in and see you and you say, well, how active are you? You get some varying answers. And then when you start drilling down, you find out that those answers are probably not as accurate as the patient thinks. Can you talk about that some now? Because this really rang home with me when you and I were talking on Monday.
Yes. So I was just technically a patient comes in and tells us we're fine, we're not having chest pain and shortness of breath and everything, and they're very active. So when you ask about activity, a patient will tell you, oh, I just do my daily activities, or can walk a mile and do okay. So I think it is definitely difficult to assess activity in general, and patients don't understand that mainly we need them to have 7,000 steps or more to really assess their functional capacity. I think they don't understand that climbing 2 flights of stairs is enough for us to assess their activity and say but they need to know more about what is being very active, and most of people think that they are, but they're not. And that is, unfortunately, since COVID, everything became more remotely, everything work, meetings, and it sadly made patients more sedentary. So people really overestimate how much they're active, and I think it's important to discuss it and explain to them what activity means. So ideally, we do recommend 150 minutes of moderate intensity, which means fast walking in a week, and also 2 days of weight strengthening. But I don't think this is the most important for us. It's mostly having 150 minutes of moderate intensity exercise a week is being very active.
And when you say that, though, what are we talking about? Just walking around the neighborhood, getting on a treadmill? What are you recommending folks do? Because I think this is when this is where the disconnect comes. People are like, oh man, that means I got to go to the gym every day. It really doesn't.
Exactly. I try to explain to patients that being active has to be a long-term plan. I don't think that I hate treadmill myself. It is boring. And I think that if they can have a good plan, a partner maybe to go with every day, 5 days a week, ideally, and then kind of consist and do it as a consistent plan for them long term, that'd be great. If they start on a very intense aerobic exercise, they may not go on after a month, maybe. They just get bored and stop it, or even less than a month, probably. But I think a sport, the ideal is walking fast outside if the weather helps, but unfortunately, sometimes it is not. Then go to malls. I don't know. Find a routine that can last long term. That's what I say to my patients.
Grocery stores may not be the best choice though to do that in, because you're going to make a stop every once in a while at the cheese aisle
Yes,
or something like that,
I mean,
right?
but it's still being active. So I had patients that switched from having food delivered to their house, but going themselves to the supermarket. It's still activity. Taking the stairs when you go to work instead of taking the elevator, which
Right.
I do, because I mean, it saves you time too, believe it or not. So I think you can implement some exercise, but also like climbing stairs is very good, is as good as fast walking. So I think that's a great thing. Up and down, up and down.
Yeah, we're looking for anything moderate or higher, which is fast walking or more,
Swimming, whatever.
yeah, swimming, biking, playing tennis. It's much more important to find something you enjoy doing or will do regularly than any particular specific thing.
And the goal is how many steps a day?
Ideally 7,000 steps. It's not the 10,000. I think 7,000 is enough a day, but we go by the minutes, 150 minutes. So technically it's going to be 30 minutes a day for 5 days a week. I think that's feasible, easily.
Yeah,
And I know this.
and I think I was going to say the important thing to remember really is that, even if 150 minutes a week seems like too much or not achievable, the most important thing you can do is go from being completely sedentary to moving at all. So there's a huge amount of progress you can make just from not having any purposeful movement to even just going for a short walk every day. So even if you can't get to that 150 a week right away, work your way up to it, because there's an amazing amount of people that are just completely sedentary in the US right now and just with no purposeful physical activity, and that's incredibly damaging.
Yeah, Dr. Eldid, I think you explained it when we talked before, that it was like if your physical activity is just getting from the couch to the bathroom or going to the kitchen in whatever order, and that's it. That's not going to do what you need to do along the lines. And so I would take it that too. You can track this, by the way. And sometimes people get a little too obsessed. Like, I have my iPhone here, which obviously has the little health app, and it does. And yes, I'm showing this out. This is embarrassing as all get out, because it's showing my average is 1,699 steps a day this year alone. That's well short of what I should be doing, right? And I'm one of those who thinks I'm actually, when I go out to a crime scene or something with work, like I go out to Galveston County Fair and Rodeo, I'm walking around and everything else. And I'm finding, even when I look back, so, well, that wasn't far. I didn't do too good on that. But y'all really reminded me of that. And I think the comparison that was made to is folks feel fine. Then they get on a cruise ship where they end up having to walk all over the ship and a lot of times take stairs. And then they go and do an excursion and they just start feeling bad. This is why they're actually taking from a really low amount of movement and going to a high level right away, and that's a pretty good sign. You're probably not doing what is best for you before you got on that cruise ship, correct?
Yes, and I've had examples. So I think anything out of the routine, like mainly traveling or doing a hike, may actually unmask some shortness of breath or even chest pain, tightness. So, or palpitations, I'm not sure that, but some change in their routine that they think is active will show some underlying symptoms.
One of the things too, and I was guilty of this for the longest time. Now that's all changed here recently, only because I had a scare. Was that folks, when they think about meeting with their cardiologist, only come at times they're feeling bad, have tightness in their chest, or they've come across a test where they need to go do it. They're not doing an annual checkup and the like. And is there more being done now to make that encouragement, making your cardiologist, your cardiology team more active in your healthcare plan? Just like your PPP, you got to have a regular visit to your primary physician, but also making sure for heart health, you're seeing that cardiologist at least once a year, getting, and seeing how your heart health is.
I want to be honest, all my new patients are being referred by PCP and really early on. And I'm impressed how it changed with years. For 4 years, during my fellowship, I've seen a big change, a drastic change from PCP sending patients just because of premature coronary heart disease in the family, sending them to me to assess their risk, and also patients with just hypertension. But it is excellent. Like we have to follow them early on when they're reaching a certain age, for sure. I'm not talking about the young ones. But I've been having a lot of new patients referrals from really no coronary artery disease, no heart disease at all. And I've been seeing them early on. And we talk about the risks in these situations, and if we need to follow up every year, and we agree on a follow-up plan with the patient. Some of them don't need anything, or some of them actually eventually end up needing a medication, like a cholesterol medication. But I've seen a lot of changes, really, nowadays.
One question along that line I want to ask, though, is that talk about the referrals come in. One of the things I think holds up folks is that I got to get a referral. Do they have to have a referral to go see a cardiologist, or can they schedule an appointment?
It depends on insurance. Unfortunately, some insurance are very particular, and they request the PCP to see the patient and assess and refer them, and that will be an authorization. But most of the insurance are okay with the patient seeing us as a first line. But in general, I feel it's better to be seen by a PCP initially if they're not seen, just to assess the whole picture. Maybe they don't need, especially if they're young, they may not need a cardiologist. I mean, it's a specialist after all. It's a specialist visit. So I think it's better to have always a first encounter with a PCP before referral. I think it's very appropriate.
But I would say if you're already seeing your PCP on a regular basis and you've made this as part of a routine, getting that referral is pretty easy. It's not going to have to be, you have to have these symptoms before I'm going to send you to the cardiologist. I think that's changed, is it not? It's no longer, you know what, let's go ahead and, I think it's a good idea. Let's get you referred.
Yeah, I mean, as the science progresses, we get a better idea of what the risk factors are that we can then the test and what they're telling us and what you can do preemptively to get people, because we don't necessarily want to just be treating people when they've got established disease. If we can if we can push the time back until that disease is established, that's great, because then people gain healthy life years. And so I think it's really important, as was mentioned, it's like, yes, you have a regular visit with your PCP. Your PCP is going to check levels of various things that will give you an idea of what's coming down the road. And then how do we push that back?
When we come back, we're going to get in with Dr. Gleeman talking about on her research. There's a lot of interesting factors on there. And then after that, we'll get with Dr. Elodie to talk about the cardio obstetrics program in more detail. And that's all coming up here in just a little bit. You're watching Healthcare Unmasked, presented by UTMB Health. And we're talking about cardiovascular medicine. If you've got questions, you can put them in the comment section on either the social media platforms we have or on the I-45 Now app, and we will address those.
UTMB Health knows that when you need advanced surgical care, you want a specialist who's an expert in their field. Our surgeons provide innovative and advanced treatment options for adults and children, for neurosurgery, GI, heart surgery, ENT, urology, and more. UTMB knows surgical care. UTMB knows you. To find a UTMB Health specialist near you, visit utmbhealth.com.
And welcome back, everyone. TJ Alds of I-45 Now. And we're glad to have everyone on board now as we are talking about cardiovascular medicine. And one of the things is the research side of things, and really diving down to that now. And that's why we're going to spend some time now with Dr. Diane Galima, who this is her area of expertise, obviously. And you kind of joked with me the other day about, that you like this because you get to go kind of down, like I use the term rabbit holes, where you can go and find something and really get in depth on it. Talk about how cardiovascular research has really changed and since you've gotten involved.
How has it changed since I've gotten involved? I was going to say, like I said, I got involved, 12 years ago, and I don't know. I don't know if I've seen a lot about how the research itself has changed. I mean, pretty much it's just a continuous iterative process, right? We learn more about something, and then you figure out that you don't actually know as much as you thought you did. So you continue on down to the next iteration, trying to figure out, where's the bottom of it. Haven't hit the bottom yet.
Right. And that was why I asked that question, because of our discussion the other day, is that as much as we think in the general world, we know about the heart and how the cardiovascular system works, we're learning something every single day, whether it be environmental, the stress thing. I wonder too, is that we mentioned about how COVID probably affected folks about their being more sitting down more, not as physical activity as much as they had before. The difference of sitting at home and working remotely, like we're doing with the show here, versus going to an office in which you're at least walking to your coworkers' cubicles or another office and the like. What is the kind of, and it's still so early on, but what's the emerging type of research we're finding the effects of COVID within cardiovascular health? Not just the disease itself, but the effects of, and this is why I think your psychology expertise on this early health, that how stress has played into this and emotional health has played into cardiovascular health as well.
Right. So yeah, COVID obviously disrupted everything, both within medicine and research. And it was, kind of a very interesting natural experiment on what happens when you completely socially isolate everybody and for a lot of people, cause them not to move around very much. And so we had some really interesting initial effects where people were just avoiding medical care whatsoever. And then we have what happens then for these people that have stayed out of care, and then they suddenly show up to care. Do we have worse outcomes because they put stuff off for so long? So we have that side as far as that. And for the research side, we had to switch everything from doing our in-person visits and doing our in-person measures to trying to figure out how do we continue to do science in a way that we can get the data we need, but not actually ever see anybody in person. And so this caused a huge change in the processes of research as well. And some of it was good, some of it was bad. I mean, the ability to do a lot of stuff remotely opened up opportunities to work with some folks that we may not have been able to reach before. But there was also downsides of the kinds of things that we could collect when we were relying on remote instruments. So it had some really interesting research implications as well. But the psychological aspects, like you said, also was just a huge effect. We saw, huge increases in anxiety and depression and social isolation as a result of COVID, and suicidality, all sorts of these just really, really serious and concerning psychological effects of that isolation. And I think we're still recovering from that. You still see that in, school attendance. You still see that in, just the general way that people are still acting, even years later. It was definitely a once in a lifetime event.
Right. And I think, though, too, in many ways is that this gives more of a chance to actually look at what kind of a community-wide or nationwide or worldwide, either way you want to place it, of those factors, the stress factor that's come in of dealing with isolation and the like, do contribute to cardiovascular health issues down the line. The most important one I think you mentioned was, and we touched on this a lot during COVID, and then right after what we call the end of COVID as a pandemic, actually, but was the fact of how many people were not going to see their doctors. particularly their specialists in cardiovascular medicine and, believe it or not, cancer follow-ups. But in cardiovascular, in going to see the cardiologist, going to see, the other heart doctors, is that those things, such as just basic testing, weren't happening at anywhere near the levels that they were before. And obviously that factor is in there. But then comes the next thing: is how much does that emotional or mental stress have on your cardiovascular system?
I mean, it's a good question. It's, hard to pinpoint the proportion of cardiovascular disease that's attributable to any one factor, but there's been, decades of research looking at both stress, anxiety, and depression as independent predictors of both development of cardiovascular disease and progression of cardiovascular disease. And they are independent predictors. They do have risk attributable to them beyond genetics, family history, the other risk factors like high cholesterol, high blood pressure. So it's obviously a factor. And one of the other issues then when you talk about these psychological factors is not only do they seem to have this independent effect on progression of disease and development of disease, but they also interfere with people reaching out and interacting with the healthcare system. So when we were talking about secondary prevention, I was talking about cardiac rehab. For us, that's depression's a big predictor of whether people actually go to those sessions. So cardiac rehab, you go to a session, you engage in structured progressive exercise, you get counseling on risk factors and stuff like that. But people with these psychological challenges aren't going to these sessions, and so they're not benefiting from these programs we have. So it's impacting people in multiple ways.
And I know too is that one of the things we're seeing, and I was talking to a member of my cardiology team, and then also talking with some of my in my psychology team when on issues I have, that changes in, because we've seen more and more kind of this, the psychological factors that have come out, and the emotional mental health issues that have come from COVID, and God, where society is on sometimes, that there's more medicines being introduced into people's healthcare on that end of things than there were before. And many of those meds, I didn't know there was like 2 hour taken that actually had an effect on my cardiovascular health. And until the doctors realized, and they were talking to one another, oh, we need to adjust that because he's got this issue over here. And that's one of the factors that a lot of times would have been overlooked before because everyone was in their silos. I think, are we now seeing in many ways that those silos are breaking down, particularly UTMB Health, as you as a researcher are able to look at that? That will help too in the long run of folks being able to deal with both sides of that factor, the meds that get into your system, whether it's from that or from other things that came up as a result.
I think one of the things I can say is that one of the upsides of this whole depressive blanket that everybody was under is we have less stigma around discussion of psychological issues within the medical field. So people are more willing to talk about challenges with anxiety and depression with their family, with their coworkers, with their doctors. And so with that reduction in stigma, then we worry less about these silos. And okay, we do know about these other things you're on. We do know what other medications we need to worry about. Because interactions between different medications is always such a serious concern. I mean, I know especially in our older cardiovascular patients, I mean, many of them might be on a dozen different medications, and then you start worrying about interactions. And I have a colleague who works specifically with that population, and he did a whole research study on trying to cut down on the number of medications that the older adults were getting, because many of them were unnecessary, and many of them were sedative type effects, and so they were just they were unnecessary and impacting people's quality of life. But if everybody is in a different group giving medications from a different specialty, then often you don't realize what the total, what all is going into a person's system.
And that's why I always refer to it as a team of there, because and this is something I learned by working with UTMB Health since we started doing the show in the middle of COVID, is that as more and more of these kind of centers of excellence open up, where you have a team working around you, but also too, the patient has a role of making sure, hey, I'm taking this, is it okay? And along those lines, and the research that's done now on the effects, because usually an FDA approval would come. It's like they're going to look at this. Okay, if you take this medicine, usually you're taking this, this, and this, and we'll see how they react with one another. What they don't do is that, well, you also have a problem over here. You're also taking this med. And they're not comparing to all the reactions when you get 8 medicines in you at the same time, what that does to your cardiovascular system, your mental health, all of it that comes around in that. What is one thing that really excites you of where your research is taking you right now?
So I really like the cardiac rehab work, the secondary prevention work that I've been doing. So the work I've done there specifically has been focusing on what we call our vulnerable populations, or our groups that don't tend to benefit from these kind of programs. So we've done a series of studies looking at how can we get these folks into cardiac rehab. And I've really enjoyed that work, because we get to see these folks that don't usually show up in these programs, and they come and you watch them recover over a couple, 3-4 months, and they look like completely different folks by the time they come out the other end. And these are people that have just high levels of comorbidity. They're in and out of the hospital all the time. So I really enjoy that, being able to make a difference in people's lives like that.
And it's also it's given them the third chance. They've already, in many ways, is how I kind of refer to it now, because the information is out there about how to prevent it in the first place. We know that everything that happens heart-wise almost always is preventable. I've always heard that from experts in your field. But when you've had one incident, it's the afterwards too. It's like, oh, I've already had. It's not like, I've had the measles. I'm not getting that ever again. It's not the same thing with cardiovascular health. You get something, you may happen again to you later down the line. So when we come back, well, I say when we come back, we're going to be talking to Dr. El Hadid, but we lost her there. So we'll hopefully we have her when we come back here. David or Becky, hopefully reaching out to her right now. But I did want to ask you, since you've been focused on the smoking, particularly younger women, and the health. I asked you this the other day, so I know this is going to be the debatable part: vaping versus cigarettes, because every time we hear enough about hey, it's cigarettes and vaping is safer. That doesn't mean it doesn't mean it's good for you. And you had some good points when we talked about this before. I wanted you to share that with our audience, the difference between the cigarettes and vaping and the mysteries and not the mysteries, but some of the debunking of saying, oh, this is safe for you. It's not safe for you, is it?
Yeah, so it's a really interesting area of research. So yes, I've spent a lot of time over the past 10 years also working in the area of tobacco, and we've done research specifically looking at effects of cigarettes versus effects of e-cigarettes, and working generally in populations who are established smokers. So for people that are already cigarette smokers, we know what the harms of smoking combusted tobacco is. Pulling all that burning crap into your lungs is the harms of that are well established, and they're really bad, and we know that for sure. And so what's less well known is, if we take the combusted element out of it, like with e-cigarettes, is that going to be a safer solution? And so for people that are established cigarette smokers, that are already smoking, if they switch completely to vaping, then yes, that probably is a harm reduction approach. We've taken a lot of the crap that we know is bad for you out of it, but that's not to say that it's safe. And also, if you're going to get any benefit from it, you need to switch completely. You can't smoke cigarettes sometimes and vape sometimes. There's no benefit to that.
Right.
So if you want any benefit, you would have to switch completely, and with hopeful long-term goal of getting off nicotine completely. But yeah, vaping, just when you haven't been a nicotine user before, it's not good for you to be inhaling. I tell my kids this, right? I don't want you inhaling anything but air. That's the only thing that's supposed to go in your lungs. Let's just leave it at that. Because it's not like these things it's not like it's water vapor or just oxygen or what. There are, elements that are involved in vaping that are used to deliver the nicotine that have unknown effects, and especially over long time periods. And they may be problematic, especially for people that have certain comorbidities and like established pulmonary disease or things like that. So yeah, I would not ever say that vaping is safe and you should just do it for funsies. That's not the message you should have there.
All right, when we come back, we're going to be talking about that exciting program with cardio obstetrics with Dr. Hadid. And then we're going to get into the really fun part, because both of you are going to be part of a panel, and you're the co-chairs of the Go Red luncheon that's happening next week, and we'll be talking about that when we come back here on Healthcare Unmasked, presented by UTMB Health.
UTMB Health knows that when you need advanced surgical care, you want a specialist who's an expert in their field. Our surgeons provide innovative and advanced treatment options for adults and children, for neurosurgery, GI, heart surgery, ENT, urology, and more. UTMB knows surgical care. UTMB knows you. To find a UTMB Health specialist near you, visit utmbhealth.com.
And welcome back to Healthcare Unmasked, presented by UTMB Health. We're talking about cardiovascular health here, as we always do in the month of April, getting ready for the Go Red luncheon, which is happening on the 25th at South Shore Harbor. We're going to have information on how you can get tickets for that. Back with us now is Dr. Danielle Hadid. And we talked about this briefly. You gave a brief description, but we wanted to get into it now. The cardio obstetrics program at UTMB Health. One, I got to ask you, what convinced you wanted to really go into this program and get it started at UTMB Health?
Well, I really got, during my fellowship, I had a couple of patients that kind of felt a bit, was tragic. I think to me, one of the cases was a 28-year-old who had a peripartum cardiomyopathy and who was actually waiting for a heart transplant, and she had 2 children. She actually developed the cardiomyopathy after her second pregnancy. And it was a pretty tragic story. She stayed 2 months with us in the CCU, but eventually could not wait any longer, and unfortunately passed. So I think in general, you can imagine how tragic it can be for a family, a husband, a mom, a sister, children, her own children. It can be very tragic to lose a mom in this situation. Most of the time, it's a delivery is always happy, but in such situation, it can be pretty tragic and sad. So I kind of was a bit more attracted to this cardio obstetrics in general, and I started reading about it and more and looking at it, and then slowly I just realized how big of an issue it is in the United States in general. It's not only in the South. Now we are much worse than other areas in the United States. Texas is indeed in the higher rates, but I think this is how I got interested, and my program supported me, and we're working on it right now. Hopefully it will grow and grow with the years go on.
And we say grow and grow, but we should really point out here, this is a first, not just for UTMB Health, but first in the state of Texas, is it not?
It is. It is. There are a lot of conferences now, yearly, on a yearly basis. They're doing conferences in ACCHA. I think the last one was in December. I believe it was the second one. But we are trying to actually implement, as I explained to you on Monday, implement some of more exposure for the fellows in MFM, in maternal fetal medicine, which is the OB that takes care of high-risk pregnancies. So we can see these patients early on and watch what they do technically. I think we lack rotations in OB in general. And I think in the near future, there's going to be a cardio OB fellowship, actually, because it is an important program in general. And I think it's going to be, it should be growing in all cities, not only in random spots.
And where are you in creating this program, man? Because as I said, you announced this just a few months ago. Where are you in getting this program up and running at this point?
I'm already getting a lot of referrals. Actually, I'm building my panel, so we're working on it. I see a lot of pregnant women, at least 2 every single day at clinic, of course. So it's a big change from the beginning, I can tell you. And it's nice. And I see also young patients that are planning to get pregnant and they are referred to me. as they may have a history of pulmonary hypertension, hyperlipidemia, familial hyperlipidemia. So I see a lot of these patients too in clinic, and we try to get the right planning as well as explanation of what pregnancy can affect, how the pregnancy can affect them in general.
And when this is really up and running in full sort, where do these patients, how do they get involved? Is it going to be a referral from their PPP? How's that going to work?
So it's from both sides. I think it's from the primary care physician as well as the OB. And I think this is the most important, but also between cardiologists. I've had referrals from other cardiologists, general, but also interventional cardiologists. So interventional cardiologists are probably involved because of valve issues in these patients. So they refer them to me too.
We're looking forward when we can follow up and follow your progress and get in the program. And the fact that you're on the ground floor of starting up a great program, and this all started with your fellowship where you saw an opportunity to create something to help with better health that goes beyond what we've traditionally seen in taking care of cardiovascular health. You're starting it off at a really good time. And we're looking forward, particularly to now that we've seen the expansion of women's health and the new children's health area and mom and baby's health that we just dedicated at UTMB Health as well. That this could tie in to making better healthcare along the way for moms and would-be moms along the way as well. And so make sure you're telling us so we can follow up with you on that. Now let's get into something that I know both you and Dr. Glima are excited about. And I should point out that unable to join us today is Dr. Ivana Garza, who's also a co-chair with the two of y'all on the Go Red Luncheon coming up next week, the 25th at South Shore Harbor in League City. Tickets are still on sale. We have a link in our comment section for you to go there. You guys are going to be part of a panel discussion that's going to be taking place there. Kind of talk about what you're going to be talking about at the Go Red Luncheon next week.
Yes, I think the focus really is on women's cardiovascular health, right? So learning about what is protective and potentially more damaging for women risk factor wise is definitely something that I'll probably get questions on.
And Dr. Al-Adid, what are you looking forward to making sure your message gets out from you to those who attend the luncheon next week?
I'll probably discuss about cardio obstetrics and answer the questions of what to look out for when you're pregnant or even postpartum, most importantly, and when to see a cardiologist in these situations or to refer to a cardiologist in general. I think it is very important, but also I'd love to speak about also women cardiovascular health in general, which I really care about also.
And as we said, we have a link about getting tickets to that next week. Still tickets available. We also have 2 tickets we're going to give away here. So if you're interested in attending the Go Red Luncheon next week, we're going to announce about an hour after the show how you can attend. Trust me, what it's going to involve is you getting something red on and also talking about Go Red and tagging UTMB Health on the I-45 Now app. We're going to announce the details of that in about an hour, so it'll be a part of that. And as I said, the two of you are co-chairs with Dr. Garza out there for that as well. I know, Dr. Al-Adid, you've got to get off to see a patient right now, so we appreciate you joining us here. Thank you all both for being on with us today. This is anything else before we wrap up that y'all want to make sure folks know of before we wrap up on cardiovascular medicine?
No, it was a
Shaking their head.
It was a pleasure. I hope to see some people at the lunch.
Yes.
We'll see you out there, and I know everybody. We were all talking about what we had for red to wear for next week as well. So we're looking forward to that. Thank y'all for joining us, and thank you for our viewers for watching us. For those of you that missed the show at the beginning, we're live now, but in just a few minutes we'll be back on the replay. This has been Healthcare Unmasked, presented by UTMB Health on I-45 Now and Pod Now.
There's nothing more important than quality health care for you and your family. That's why UTMB Health is in the communities where you live, providing easy access to innovative care. At UTMB, we know our patients need personalized care to lead healthy and fulfilling lives, providing everything from primary care and specialty care to urgent care and emergency medicine. UTMB knows healthcare. UTMB knows you. To find a UTMB doctor near you, visit utmbhealth.com.